That's great. Can I thank you, Chairman, and the members of your committee for your invitation to update you on our COVID-19 response. And I'm joined today by Deputy Chief Medical Officer Dr. Ronan Glynn and Professor Philip Nolan, the Chair of the Modelling Group, as you've said. I'll provide an update on the current epidemiological situation, the impact that our vaccination programme is having on the risk profile of the disease, and recent developments regarding further easing of public health restrictions, as you've requested. I also have a short slide set with me today, and I can take members through that if it's helpful and of value in better describing the current epidemiological situation and related matters. The last 18 months has seen a considerable burden placed on individuals, communities and on society as a whole. And we wish to thank the public for their solidarity to date and their continued efforts to help to stop the spread of COVID-19. We also wish to extend our sincere sympathies to those who have lost loved ones to COVID-19, despite our collective best efforts as a society. The epidemiological situation in Ireland at present indicates high incidence with a somewhat uncertain trajectory. While incidence in those between the ages of 19 and 24 and between the ages of 13 and 18 has fallen sharply in recent weeks, we have noted an increase in testing rates and confirmed cases in children between the ages of 5 and 12. This trend, and in particular the impact of the return to school and the opening of the third level sector, will continue to be monitored closely by us in the coming weeks. The total number of confirmed cases of COVID-19 in hospital has begun to reduce, and the total number of confirmed cases in the intensive care units has also stabilised recently. There continues to be low mortality relative to the number of COVID-19 cases. While the majority of infections are occurring largely in the young, unvaccinated population, the current force of infection is resulting in a significant number of infections in older, unvaccinated people. At the same time, the number of outbreaks notified in settings with vulnerable populations, such as in nursing homes, has increased in recent weeks, and this is also being closely monitored by the HSE in the first instance, and also by us in the National Public Health Emergency Team. Ireland's COVID-19 vaccination programme continues to make significant progress. As of the 14th of September, 88% of those over the age of 16 and over are now fully vaccinated, with 90% having received at least one dose. Vaccine uptake and completion has been very high in all age groups, ranging from 81% completion in the 16 to 49-year-old age group through to 95% completion in those between the ages of 50 and 69, to an almost universal vaccination in those aged 70 and over. However, vaccination has been offered to younger people relatively recently, and many younger cohorts have yet to receive their second dose. Those aged between 16 and 29 years, given their high levels of social contact and partial vaccination, have still the potential to sustain a large wave of infection until such time as this cohort achieves very high levels of immunity through vaccination. Fortunately, the uptake in those younger cohorts is high. COVID-19 vaccines are providing very effective protection from severe illness and have fundamentally changed the risk profile of this disease. This will facilitate a transition in our approach to managing the pandemic over the medium term, entailing a shift from a focus on regulation and population-wide restrictions to one which is more appropriately based on public health advice to facilitate the exercise of personal judgment and personal protective behaviours. However, notwithstanding the great benefits that vaccines have brought, it is still likely that this Delta variant will continue to circulate extensively, globally and in this country in the coming months, particularly among individuals who have not yet been vaccinated or those who have not been fully protected as yet through vaccination. In the context of this highly transmissible variant, it is unlikely that vaccination alone, even at the very high levels that we're achieving compared to many other countries in the world, will bring the effective reproduction number below 1. And this means that through the autumn and the coming winter, possibly in the face of high levels of infection, we will remain dependent on high public understanding and buy-in to the basic public health measures that we have emphasised all the way through this pandemic in order to minimise opportunities for transmission of the virus. Therefore, there will be an ongoing requirement for clear guidance and communication for the public on the evolving disease profile and the strategies that they can take to mitigate those risks. A focus on the vital importance of rapid self-isolation for those people who have symptoms of respiratory viral infections, a partnership approach between employers and employees to ensure that the importance of self-isolation when symptomatic is both understood and communicated as well as facilitated, sector-specific measures to ensure safe environments, including formal requirements for mask wearing in certain settings such as healthcare, indoor retail environments and on public transportation. And importantly, robust public health surveillance and response capacities, including our testing, contact tracing, surveillance and sequencing capacities for COVID-19. Throughout the pandemic, focus has remained on protecting those most vulnerable to the severe impacts of COVID-19 and on protecting health and social care, education and childcare services, and these continue and will be to be prioritised. The continued burden of COVID-19 and the significant backlog that has emerged of non-COVID care, but due both to the demand for COVID care in the early part of the year and the recent ransomware attack suffered by the HSE, means that our health and social care system, and in particular the hospital system, remains in a challenging position. Should COVID-19 admissions begin to increase once again, this will place additional pressure on the hospital system and will have a significant impact on the delivery of non-COVID care. Chairman, we cannot predict with certainty the future trajectory of this disease, and constantly we can't rule fully out the possibility of the reintroduction of any given measure to enable us to respond to the disease and what challenges its transmission might pose for us. And we must continue to ensure that our response is agile and flexible and gives us an ability to pivot and change course rapidly in response to any emerging threat that might arise. And we're happy to take the chairs. And as I said at the outset, Chairman, we have some slides that may facilitate the discussion if you wish to share them with you. Thank you.
On the next speaker, Professor Karina Butler.
Good morning, Mr. Chairman, deputies and guests. Thank you for the invitation to attend today. The rollout of the COVID-19 and seasonal influenza vaccine programmes are managed by the HSE. I will update you on the need for the COVID-19 vaccine boosters and NIAC seasonal influenza vaccine recommendation. NIAC brings together a broad range of experts to formulate its advice. Its members regularly participate in meetings of the WHO and European advisory bodies on immunisation. NIAC has sent comprehensive recommendations to the Chief Medical Officer on issues regarding the COVID-19 vaccination programme relating to priority groups for vaccination, vaccine safety, pregnancy, children and adolescents, and most recently booster vaccinations. The most effective way to prevent COVID-19 related hospitalisation, severe illness and death is to ensure that all eligible people are fully vaccinated. They are strongly encouraged and should be facilitated to complete their vaccination course. An additional COVID-19 vaccine dose may be required because of one, an inadequate protective response to the first course, waning immunity, or the emergence of resistant variants. Additional doses are often collectively referred to as boosters. However, distinction should be made between the need for an additional dose where the initial scheduled course is inadequate, and we refer to that as an extended primary course, and the need to reinforce a waning immune system or waning immune response, that is, a booster dose. An additional dose or doses of the original or a modified vaccine may also be required to protect against a resistant variant. Those with severe immunocompromise, for example, after organ transplantation or receiving immunosuppressive treatments, may not have adequate protection following a primary vaccine course. And for them, an additional primary dose increases the likelihood of achieving protection. Residents of long-term care facilities and many older people living in the community have suffered severe disruption to their quality of life, with negative impact on their psychological and social well-being during this pandemic. This group have a poorer response to the primary vaccine course and more rapidly waning immunity because of their age and underlying medical conditions. In order to optimise their protection, NIAC has recommended that an additional vaccine dose should be given to all of those aged 12 years and older with immunocompromise associated with a suboptimal response to vaccines, those aged 80 and older, and those aged 65 and older who are living in long-term care facilities. NIAC has recommended that the COVID-19 and seasonal influenza vaccines may be given at the same time or separated by any interval. This will allow the uptake of both vaccines to be optimised. This year, an adjuvanted quadrivalent influenza vaccine is recommended for those aged 65 years and older, as it provides better protection for this age group. NIAC continues to examine the evidence regarding the need for booster COVID vaccines for other age groups. These include those at increased risk of severe COVID disease, other older persons, healthcare workers, because of their pivotal role in providing essential health services. Consideration for booster doses takes into account whether the additional doses are safe, if they're needed, and can they provide benefit. Influencing factors includes community levels of circulating SARS-CoV-2 and the impact of the high vaccination rates in Ireland, with over 90% of adults fully vaccinated. This high uptake is a testament to public health confidence in the programme and credit to all involved in the development and rollout of the vaccine programme. NIC is conscious of the global demands on vaccine supplies and recognises that facilitating vaccination on a global level is important on a humanitarian and global equity basis and essential to limit the continuing threat of COVID-19 in Ireland. NIC is cognizant of the WHO position and advice on global vaccination and our duty to address inequities. Until global control is achieved, all countries remain at risk and return to normality will be compromised. Vaccines are a global public good for the benefit of all. NIC is mindful that low and middle income countries have insufficient doses to protect those most at risk. Less than 2% of people there have received a first dose of vaccine, and it is estimated that many will not receive a vaccine until late 2023. Ending the pandemic requires global cooperation. Failure to mitigate high community transmission of SARS-CoV-2 in any country can facilitate the emergence of resistant variants and prolong the global threat. NIC welcomes Ireland's participation in the COVAX facility, which supports low and middle income countries in vaccine access. NIC encourages the government to continue with and expand its commitment to the global coordinated effort based on the principles of solidarity and to foster equitable access to COVID vaccines. In upholding the principles of moral equality, minimising harm and fairness, as set out in the National Allocation Framework for Equitable Access to COVID vaccines, NIC seeks to protect those most at risk from severe COVID while recognising that access to life-saving vaccine by those most at risk should not depend on country of origin or residency. As stated by the European Group on Ethics in Science and Technologies, it is more important than ever in this difficult time to uphold a form of solidarity that is inclusive of everyone and which recognises that respect is due to everyone and not exclusive to those that live in our own town, country or region. NIC acknowledges the significant support of our voluntary members and the collaboration with and by all involved in the vaccination programme in pursuing a common goal of reducing deaths and severe illness from COVID. Through maintaining confidence in a high-quality vaccination programme, we can maximize vaccine uptake and reap societal benefits. Thank you for your attention.
Thank you, Professor. And we now move to open the meeting to the floor. And we have already received notice from three speakers, Senator Martin Conway, Deputy David Cullen, Deputy John Lahart. In their turn, starting with Senator Conway, you have 10 minutes. And I would ask all members to observe the time limit and to stick to the subject under discussion. Senator Conway.
Good morning, Chairman, and good morning to our guests. And like everyone else in the country, I want to start off by sincerely thanking Dr. Houlihan and Ms. Butler and Dr. Glenn and their teams for the outstanding work they've done on behalf of our country and our people. And we are eternally grateful for the efforts and the leadership that you all have shown over the last 18 months. Dr. Houlihan, I was a little bit concerned in terms of your statement about the outbreaks that you spoke about in nursing homes. And obviously nursing homes is where the most vulnerable of our society live. And I'd just like maybe if you could elaborate a little bit on those outbreaks, and is there any specific reasons for them outside of the standard reasons that we would expect in terms of community transmission and so forth? Is there anything unusual about them? Is it possibly down to maybe some staff not being vaccinated? It's very concerning, and the fact that you've noted it and that you're monitoring it very carefully is obviously a concern. So maybe you might just share with us a little bit more information on the outbreaks in nursing homes.
Senator, Professor Butler, who wishes to go?
Dr. Houlihan, maybe?
They're on, yeah.
Dr. Houlihan.
Chair, sorry, I thought you were taking 3 speakers at a time. Apologies.
Well, we'll start off this way. We might change as we progress if we are successful.
Whatever works for you, we're happy. So just in relation to the nursing homes, we have some specific data. Yes, we're keeping a close eye. We have experienced a number of outbreaks over the recent times in nursing homes. I mean, the first explanation for that is obviously what we call the force of infection. There's just so much infection out there in the population, and there's certainly, although it's reduced somewhat in recent weeks, the level of infection meant that if you have a situation whereby we don't have 100% vaccination, and we do have very high levels of vaccination, we don't have a vaccine that is 100% effective, then we're always going to have some people who are vulnerable if they encounter another individual to transmission and to picking up that infection. And that's exactly what's happened within our nursing homes. It's also what's happened in these age groups in the community. We've seen a rise in the incidence in the corresponding age groups in the community. So there's a couple of things that kind of leads us to. One is, and perhaps Professor Butler will wish to speak to this, will be question around the decision that has now been made to accept the advice of NIAC in relation to boosting vaccination for people who are residents in nursing home facilities and who are over the age of 65. There's also the continued importance of maintaining high levels of compliance with infection prevention and control. That continues to be, it's every bit as important now today as it was at the beginning of this pandemic. That we do everything we can within our nursing home communities for the patients and for the staff to maintain high levels of infection prevention and control. You've partly answered your own question in what you said in your remarks in relation to staff. And even though we have high levels of vaccination in staff, we do believe that there has been a challenge in some nursing homes in maintaining high levels of staff, particularly perhaps among those people who work in nursing homes, but who actually come from agencies, and maintaining a focus on ensuring that we don't deploy staff who are not adequately vaccinated, if that can be avoided at all, is at the core of what the HSE is trying to do in terms of its management of nursing homes. There's a couple of things that we'd say just in general terms, and I might ask Dr. Glynn to share some of the data with you in a second, the specific data. We have a lot less of this infection than we had for corresponding levels of infection at previous times in the epidemic. That is good news in terms of the level of protection. And for those people who pick up this infection in the nursing home communities, the impact of that infection in terms of, we didn't always have very high levels of hospitalisation as compared to perhaps other parts of the population, but the effect in terms of mortality, very, very different experience. And although we have had some mortality in these, it's of a much lower level than we would have experienced at previous points in the pandemic when we didn't have the benefit of vaccination protecting these people who reside in those locations.
Okay, have you any specific figures in terms of numbers of people within the nursing home environments that have picked, that obviously have caught the disease, and maybe just sadly in terms of the mortality, is there any specific figures available in terms of the number of people we lost?
We do have that, Senator. Yeah, we'll share it with you now. Yeah, Dr. Glynn.
Thanks, Senator. So we have data from June the 27th to September the 11th inclusive. So over that period, there was 7 outbreaks in community hospital or long stay units and 51 outbreaks in nursing homes. That's 58 outbreaks in total. And then across those 58 outbreaks, there was 896 cases recorded, of whom 31 were hospitalised, so 3.5%, and of whom 31, unfortunately, passed away. So again, 3.5% mortality. And then last week, there were 4 new nursing home outbreaks reported with 24 confirmed cases.
Okay, and just in terms of the booster programme that you spoke about, Dr. Glenn, maybe Professor Butler might just go into a little bit more detail in terms of what the plan is in terms of rolling out the booster jabs to long-term care facilities and nursing homes.
I'm happy to talk to that indeed. In terms of the booster programme, the reason that we have recommended the booster shot for those living in the nursing homes and for those over 80 years of age was because we know that they have particular vulnerability in terms of, first of all, their initial response isn't as good overall. Now, some people within the cohort will have very good responses, but if you take those groups as a whole, they won't respond as well as younger age groups. So their primary response isn't as good. And then secondly, and this has been supported by data initially from Israel, but now also from Public Health England.
In other words, to help clinicians to determine when it's necessary for them to do so, whether they're dealing with a case of influenza, a case of COVID, a case of RSV, or something else. And so it'll be the sum total of all of those kinds of requirements that will generate our need for ongoing PCR testing, at a very different purpose and perhaps a different scale than the testing that we've been doing up to now.
Okay, thank you. That's very interesting. If those numbers are there, I might end it there, Chair, if those current numbers on schools.
I'm going to bring Dr. Glynn in, if that's okay, Deputy.
Yep. Thank you.
Last week, so the week to Saturday night, there were 40 new outbreaks reported in schools with 191 linked cases. 34 of those outbreaks were in primary schools, 3 in post-primary and 3 in special education.
Okay, thank you, Chair.
We now move on to Deputy Gino Kenny, who has 7 minutes starting now.
Thanks, Cahirlock, and I'd like to thank NIAC and NEFIT for all their work in the last 18 months. It's been a very trying 18 months for everybody in this country. Just two questions. One question is in relation to Dr. Houlihan's statement in relation to the future trajectory of this disease. And we all know that it's quite it's evolving, it's unpredictable. But what point of the trajectory of the disease does NIAC and NEFIT see, if it goes on in an upward kind of spiral, what point do measures be reintroduced in relation to what has happened in the past? What kind of point do we need to get, as in ICU, people in ICU and people being hospitalised in relation to the disease?
General remarks. I mean, our hope and expectation is that we won't find ourselves in that position, and we're going to express cautious optimism that will remain the situation. The scenarios that might arise that could give rise to those requirements will be potentially in relation to new variants and emergences of challenges that at the moment we don't see any signs of on the international sphere. What you've seen over the course of the last number of months is the emergence of this highly transmissible Delta variant, which appears to have suppressed the spread of many of the other variants that did have this so-called vaccine escape potential. In other words, vaccines weren't as effective against. And even though there is some impact in terms of Delta, in terms of the effectiveness of vaccines, it isn't as great as perhaps with some of the other variants that were identified as variants of concern. And we've seen a suppression of those because Delta has essentially taken over transmission in the world. And so on the basis of our experience of Delta, how we think things are going in this country, we think things at this point in time are going better than they're going in perhaps the 4 regions of the neighbouring country of the UK. And it gives us a basis for expressing some cautious optimism that we won't need to go back the road in terms of some of these kinds of restrictions. The 2 things that are going to influence that are the very high levels of vaccination that we've achieved and maintaining that. And then second of all, that the extent to which the public keeps up compliance with the basic and simple, you could say, bog standard guidance that we've been given in relation to social distancing, mask wearing, avoiding indoors, the importance of being aware of the circumstances in which transmission is likely to arise. And that's where the ventilation question comes in. And there was an extensive component, our last letter of advice, dealing specifically with the question of ventilation in the letter to the Minister, just in response to the question.
Dr. Holland, if measures were introduced, what would then measures be? Well, if obviously it's a very hypothetical situation, but if that happened,
it is a hypothetical situation. I mean, if you could have posed that question to me 2 years ago, Deputy, before this all began, I never would have had in my answer to any hypothetical question 2 years ago the kinds of things that we found ourselves recommending to government, to be closing retail, to be closing international travel, to be closing schools and universities, and so on. I never would have envisaged that, even though I would have known that these things were theoretically possible, if you'd asked me this question 2 years ago as a hypothetical question as you're asking me now, I never would have, it wouldn't have featured in any way in my answer. And yet all of these things have become part of your reality and my reality and everybody else's reality for the last 18 months. So it's too hypothetical a question for me to address, I'm afraid.
Okay. Just my second question is in relation to the opening of schools and children between the age of 5 and 12. This is to Professor Butler. And as we know, This disease has killed millions of people across the planet, and largely children of that age group have come unscathed in relation to death. It's obviously disrupted everybody's lives across the planet. So schools in this country have opened in the past 2 weeks. How satisfied is Professor Butler in relation to the protection of unvaccinated children of that age group? And, has she confidence in relation to the measures the government have done thus far?
From the point of view of NIAC and from the point of view of vaccination, at the moment there is no authorised vaccine for children in that age group. There are currently studies ongoing looking at what dose might be necessary and indeed whether it is needed for children. So from NIAC's perspective, we have no recommendations in terms of vaccination for children. From the general public health perspective, I'm sure Dr. Glynn or Dr. Houlihan may want to speak to that. But in fact, I think what has been done in our schools, the schools indeed, and the school systems have really taken on board the need to keep that environment a safe environment for children. And I think to a certain extent, we are very fortunate. This infection has been different from many other infections in that children, when they do acquire infection, it still remains the case, even with the Delta virus, that for the majority of them, it is a mild infection. And in fact, that may contribute to their overall immunity ongoing. So in terms of from NIAC's perspective, there is no recommendation regarding vaccination for children at this time.
Professor Butler, I'm going to ask a very, very obvious question. Why is that? Why is it the case that children have come largely unscathed in relation to this terrible disease?
I think it's a very interesting question to ask. It may be to do with their immune system and its ability to either tolerate this virus and not get the kind of hyperinflammatory system that we have seen in some of the adults later on. I think it's a key question to be answered generally, but one of the things that we see very often with these coronaviruses, other coronaviruses in the family, the children get it, have very mild illness, and then as adults, we are not troubled by it later on.
Okay. I think I've run out of time, so thank you. Thank you.
Right out, you have a couple of seconds, but we move on to the next. Thank you, Deputy. We move on to the next round of speakers, which is in the same 7 minutes. Deputies Colin Burke, Annie Hoey and Cathal Crowe. In that order. Deputy Colin Burke, you have 7 minutes starting now.
Thank you very much, and thank you to Professor Butler and to Dr. Houlihan for the work, and indeed their committees for all the work that they've done over the last 18 months. It has been a difficult time for everyone. I just want to go back to the issue about the, I think it was a letter that was sent to the Minister back on the 25th of August, setting out the kind of likelihood of the number of people contracting the virus over the next number of months. And it sets out about peaks. And I'm just wondering about the increase in numbers. We will know, and over the last week or so, we see all universities returning. We're talking about around 220,000 students moving from home or moving from work back into third level. And I'm just wondering, in relation to that peak, do we expect that this will be a contributory factor now? And at what stage do we think that this will start playing out, and how do we work towards trying to reduce the level of people contracting the virus over the next 3 to 4 weeks, because it's a huge number of people moving in a very short time scale.
Thank you very much, Senator Burke. I might ask Professor Nolan, if that's okay with you, to address that question.
Yeah, very briefly, and just to broaden it, I mean, the first thing is in that age group, 19 to 24-year-olds, incidence has effectively collapsed in that group as the vaccinations have become effective. So we've gone from 100 cases per 100,000 people per day in early August in that age group to below 40 cases, so a 60% reduction in the incidence in the university-going cohort. That allied with the mitigation measures that universities have put in place around reducing crowding and mask wearing in the vast majority of indoor settings, the installation of CO2 monitors to ensure adequate ventilation. We've modelled scenarios where things might go wrong, but based on what we've seen over the last period of time, we wouldn't expect a significant wave of disease as that group of students returns to third level, but it'll have to be monitored. Just to broaden it out, last year when we opened schools, the demand for testing tripled and the incidence went up about 50%. In the last 2 weeks, as we've opened schools again from a higher base, demand for testing has tripled. We're now testing close to 1% of the primary school going age cohort every day. And that's good, it's prudent. It means that if there's any resurgence of disease or surge of disease in that age cohort, we'll see it. But that increase in testing, threefold increase in testing, is again translating into about a 50% increase in detection. They may have been infections that were out there in the summer. In other words, it may be now that we're detecting cases that with lower testing during the summer, we weren't detecting their equivalents in July and August. I just want to make a final point on mitigation measures in third level and schools. There is a great deal of discussion about the balance between ventilation, mask wearing, hand hygiene, and so on. I think it's really important to state that even though people may say that they think aerosol transmission is more important than other modes of transmission and therefore ventilation is as or more important, we simply don't have the evidence to back that up. What we know is that the virus is transmitted by some mix of direct contact, short-range droplet and aerosol transmission where we're close to each other and literally spraying those droplets in each other, long-range aerosol transmission and surfaces. And even though we know surfaces probably don't matter much, we simply don't know the balance between the others. And our public health doctors tell us it's usually close contact. So it's very important in the public health messaging that we get the balance right, that hand and respiratory hygiene remain important, physical distance and mask wearing remain important, and ventilation remains important. But there's no way of knowing which of those is more important. So we need to...
Can I just ask on the modelling, where do you think that, do you think that the dates for that peak is changed now? And do you think it will? Or do you think that we're not, the worst possible scenario is not likely to be met now, even, when you give the information in relation to third level? And the second thing I just want to ask in relation to the number of people between 16 and 29 who have received one vaccine, have we any idea of what total number have received both doses?
So I'll answer the modelling very briefly, and then Dr. Dinh might answer the vaccination. So we model a range of scenarios to be prudent from what we call conservative or optimistic out to pessimistic. And in advising government recently, we had evidence that we were more likely to track the optimistic scenarios. And the basis for that optimism is the very high levels of vaccination. And the fact that if we look at the population in general, even though we're getting back towards normal, people are still being very prudent in terms of their observation of the basic measures, hand washing, hygiene, ventilation. So on that basis, it's plausible that we're past the peak of infection in this population. So the most optimistic scenario shows the peak having happened in the last week of August, first week in September, and case numbers start to decline from there. And that seems to be what we're seeing at present.
Can I just ask one final question, and that's in relation to nursing homes? We've had outbreaks in nursing homes, and we're talking about doing further vaccination in nursing homes. Can we include the staff in nursing homes in that vaccination programme? Because if we've had outbreaks there where, it has a detrimental effect once there's an outbreak in nursing home, can we include staff in that in that programme?
I might ask Professor to address that question, if that's okay, in the context of the NIAC advice.
There hasn't been the evidence to support the need for a third dose of vaccine in staff who have already been vaccinated. And I think the emphasis in that situation has to be in ensuring that all staff are vaccinated and facilitated in whatever way to become vaccinated. So in studies that have been done, the antibody levels in staff are very different from those in the nursing home residents. And I suppose the other consideration is we have to be mindful that the vaccines are a scarce resource, and that in using them, there are three things that we have to be happy about. One, that a third dose is safe. Two, that it's actually needed. And three, that it will achieve what we set out to do. So in terms of the healthcare workers, that is a group that we were keeping under consideration because of their particular role. But as yet, the evidence hasn't supported a need for the vaccine in that group for those who are already vaccinated.
And can I just ask finally in relation to nursing homes?
We have to move on.
In relation to frontline staff, I know we've very much focused on frontline staff like nurses and care assistants, etc. The other cohort are people who deliver services to nursing homes. Have we focused on making sure that they have been vaccinated as well?
Thank you, Deputy. We're way over time. Can we have a written reply or a quick reply? What do we think? Written reply it'll be. Next speaker is Senator Annie Hoey.
Hi, hello everyone. Hopefully you can hear me okay.
Yes.
Let me just angle this up a bit better. So I just have three kind of questions around three areas, and it's just coming to, first of all, around children, if I can circle back around to that. It's around the idea of, mask mandates, and as you said, there's not going to be recommendations necessarily around vaccinations for children in the way, but it just seems, there are enormous number, obviously it was inevitable that was going to happen, that there was going to be an enormous number of children going to be getting tested and are in and out of school. And I just want to come around on the comment that you made, Dr. Butler, in terms of perhaps actually it can build immunity. It's I'm just wondering how we marry those two things together in terms of the potential that actually, and some commentary, I've heard other commentary on this in terms of well, look, if children get it, it's not as serious. So I don't mean not as serious, but there's the evidence would maybe imply that it could indeed perhaps boost their immunity or anything like that. So I'm just wondering how we married the two together, that we have children and they're being sent home and they can't come in, and all of these other kind of things, the restrictions are quite hefty, I think, on school settings. And obviously school settings have more than just children in them. There's teachers, there's SNAs, there's clerical staff, there's janitors, there's lots of people. But just, we're getting a lot of contact from parents just being like, our kids are just not in school. We just, it just seems to be that and so I'm just wondering, how do we tie those two things together in terms of, how do we say to parents, this, if that's what you're saying, that this is not, because I think there is a lot of concern out there. So maybe just a bit of clarity on that, if you wouldn't mind, Dr. Butler.
Well, first, I wouldn't want anyone to misinterpret what I was saying, in the sense this is saying that it's a good thing to have your children get this infection akin to the chickenpox parties that people talked about. No, I am definitely not saying that. And our onus is to protect our children from this infection, because while thankfully most of them have a mild illness and don't suffer consequences, there is the potential for significant illness, and there is the potential for the post-COVID inflammatory syndrome that some children can have. And when we talked about it earlier, and one of the deputies mentioned the numbers where there were thankfully as little as 30 children in ICUs related to COVID since the beginning of the pandemic, and only 8 of them were PCR positive at the time, saying that that was in the acute infection. The others were there related to the inflammatory syndrome. So COVID is not something that you want to expose your children to. And that's where it comes into, because the whole thing is around reducing the force of infection in the community and having those people around the children vaccinated and protected so the children don't acquire infection.
Thank you for that. And I wanted to actually give an opportunity perhaps to just expand.
Thank you. I appreciate that. Because I would not want it to be misinterpreted.
Yeah, no, I just thought I could see how this could, as we know, things can grow and get quite wild. I just wanted to thank you for that. So I suppose just two very quick last things. it's just around, you know, the ventilation in schools, that there's been the delay in the ventilation equipment, if you will, that there was a fault in some of them. Is there any concern that that's going to have a knock-on impact, you know, that there will be increased that, you know, I know that the article said that they'd hopefully be all in by next week, but is there any concern around that ventilation equipment, or are we just kind of hoping that everything will work itself out? And then the last thing, you know, second and third boost of vaccines when we still are desperately waiting for vaccines. And then, and I know that you've said that it'll be make sure that they're safe and actually needed. And I suppose the second thing around boosting vaccines, is there any conversation around boosting vaccines for particular vaccine types that people would have gotten? So I would have friends, for example, in Iceland who have already gotten their booster vaccine because they got the Janssen vaccine, for example. Is there any conversation around the different types of vaccination people would have received and how the booster, or is that just going to be too complicated?
No, I think all of the issues you bring up are issues under consideration. And what we do know is that use of heterologous vaccines, using a different vaccine for a second dose or now for a third dose, actually produces a good immune response. And there has been data, also just some emerging data, for example, if someone has had an RNA vaccine in the beginning and they get a viral vector, in this case a Janssen vaccine, that can also produce a good response. So it does seem that we're gathering enough data to say that from an immune response point of view, if vaccines are mixed in that way, that you can get a good immune boost. But then it becomes down to, well, what's the best way? And that data is coming out, and in fact should be out. There should be some more data even within the next week in terms of studies that are going on in the UK. But for now, we're happy to use a RNA vaccine to boost those for whom we have said they need a booster, irrespective of whether they've had a viral vector vaccine or an RNA vaccine.
Okay, thanks. Those are all my questions. Thank you.
Thank you. Thank you, Senator. We now move on to the next round, which is in the names of Senator Francis Black, Deputy Sean Crowe, and the Chair, and see how we go. And incidentally, we will, if we have time, we will have an extra round, third round as well. So, Francis Black.
Thank you very much. I hope you can all hear me okay. And firstly, let me start by saying thank you so much for the phenomenal work that you have all been doing in the last year and a half. I can only imagine how difficult it must have been at some times throughout the pandemic. I suppose the first question, it kind of links in a little bit to what Annie mentioned there. In your submission, you mentioned the additional COVID-19 doses or boosters as a way of protecting people against resistant variants, especially those with severe immunocompromise. I just really wanted to ask, how do we reconcile the need for boosters with global limited vaccine supplies? And do you think without global cooperation, are we prolonging this global threat? So that's the first question, and then I'll have just one or two after that.
And Professor Butler will want to comment on this. I mean, our role and responsibility is to provide advice and guidance to the Irish government through our minister around decisions that get taken in the best interest of the Irish population, and obviously that's the role that we carry out and we take seriously and so on. The points that you're making in relation to global, of course we understand, and we understand the nature of infectious disease in a global context. And until we achieve global control of this disease, there's still going to be a risk to every part of the globe. And that remains the case, including the emergence of variants. And in particular, maybe some of the progress that has or hasn't been made in some countries, maybe some wealthier countries where vaccination uptake hasn't been as good as it's been here. It's almost a little bit like, I'm sure you're familiar with when you half complete your course of antibiotics, that increases the risk of emergence of resistance. The kind of half vaccinated population presents a particular challenge because it's not going to suppress infection, and it's going to continue to offer an opportunity and perhaps select out those viral strains that have a competitive advantage in terms of vaccine escape. And so we look at all of those, we're concerned about all of those kinds of things. See, our role and responsibility in the context of all of that is to give advice and guidance to how we maximally protect the Irish population.
Thank you. Just then, sorry, I hope this question wasn't originally asked, so forgive me because I just stepped out of the office there, but is there any plans for NEFA to scale back on response capacity, such as testing in light of the successful vaccination programme?
In a word, yes. We think we're not far away from a point whereby all of the criteria that we set out in the advice we provided to government, which is accepted as the basis upon which we might consider moving to another phase, if you could put it in those terms, in terms of our management of the pandemic. That was the basis ultimately that we advised government. Government then identified a series of dates for the easing of certain restrictions. So, for example, next Monday, some of the measures in relation to workplace will kick in, if you like, and then a final date identified of the 22nd of October. We think we're not far away from the point of achieving those criteria, which on the one hand will look at our vaccination uptake rate, the target of 90% for the over 16s. We're very close to at this point, which is almost an unprecedented thing to be able to say in comparison to other countries, but also in terms of the features of the disease and its behaviour, having the disease as, let's say, doing what we wanted to do. And we see a lot of encouraging trends at the moment in terms of the downward incidents that we've seen in some of the age-specific groups. We want to see that continue and to monitor, as we've been discussing, ultimately the impact of the return to schools and some of the other measures that were eased in the early part of September before we're in a position to advise in relation to those criteria moving on. But we're optimistic that we're close to that point. And at that point, then I think it will change utterly the environment in which we consider testing. Whereas heretofore we were testing every single case, we were advising every single individual who had symptoms to contact a GP to arrange a test. We provided walk-in facilities for people, online facilities for people to book tests and so on. I think what will have to happen is that we evolve our management because of our success in achieving all of these indicators to one whereby we test, obviously to support clinical decision making. So doctors in clinical situations who need to determine whether a sick patient is sick because of influenza or COVID, because that could influence the management of that particular patient, but then also for monitoring purposes, what we call surveillance, which will be based on our primary care surveillance system, on surveillance of things like wastewater and maybe some other forms of surveillance happening in third level sectors I've mentioned previously, and then in those environments where we have particularly sick and vulnerable people. So a very different form of testing and a very different purpose, and our contact tracing arrangements and the wider parts of our public health management evolving to reflect a situation where we now have a population which, if I can put it in these terms, we have to regard as being as protected as it can be from vaccination, from the huge effort that's been made to get as many people vaccinated as possible. Still, our hope and expectation that even those small remaining numbers of people who remain to be vaccinated come forward for vaccination. It's true to say that if you look at the entire population, even though we've done as well as we have, we probably have well over maybe somewhere between 1 and 1.5 million of the population that isn't vaccinated, either because they're children or because they haven't come forward for vaccination. So there's still time, there's still vaccine, there's still capacity to deliver vaccine on the part of the HSE. And if you're an individual out there, or if you have influence over individuals who are not yet vaccinated, that's still the most important thing that an individual can do.
Thank you, Doctor. One final question, and I hope you have a little bit, just even 30 seconds to respond. As a committee, we heard from a group of medical experts about the importance of vitamin D, and as Roisin mentioned, we also had a group in talking about the importance of ventilation. So I'm just wondering, is this something that you might consider highlighting in your public messaging campaign, which I'm really delighted to hear that there will be another public messaging campaign, communications campaign. But I do think, or what's your thoughts on the vitamin D and well, you've talked a little bit about ventilation, but just on vitamin D and highlighting the importance of vitamin D going forward.
Thanks, Senator. Dr. Glynn might just address that question.
Thanks, Senator. Just very briefly, ventilation will certainly be a key component of the messaging through the autumn and winter. And in relation to vitamin D, if we just leave COVID aside and the different views in relation to vitamin D and COVID, what I can say for certain is that significant proportion of our adult population in this country are vitamin D deficient. And if COVID never came along, we should be encouraging people to get adequate levels of vitamin D, particularly as we move in again to autumn and winter. So yes, that should be a component of our public health messaging more generally, regardless of COVID, over the coming months.
Thank you very much. Thanks, Cahirla.
Next, Deputy Sean Crowe.
So he's not available. You'll have to read out his questions.
We'll have to read out the questions. Have we got his questions? Okay. The first question is, does NPHET believe that this is the right time to wind up self-referring testing centres? Monday saw over 21,000 people apply for testing in one day, the highest one-day amount since the pandemic started. Can we have a reply?
Sure. As we
and
said,
if we run out of time, we make sure that we get written responses. We'll go as many as we can. Thank you.
As we've said already, a significant component of the testing we're seeing going on at the moment is driven by a very sharp increase in testing of school children, which we've seen at previous stages in the pandemic. To answer his question, today is not the day, but we think we're not far away from a point of those criteria being met, whereby we think changing the regime of testing along the lines I've previously described, and in the interest of time I won't describe it again, changing the purpose, because we're in the happy situation that we've such high levels of vaccination and all of the other criteria being satisfied that enable us to have the confidence to say that we change our public health management, which is not the same, Chairman, very important to point out, as promising that this disease, which will be with us, won't continue to cause a challenge both for individuals who pick it up, who will end up having severe infection, who may end up being admitted to hospital and ICU, and we will see some mortality. And that will be a continuing feature of our management of the disease, as well as outbreaks in some settings, particularly where those settings involve the gathering of large numbers of unvaccinated people. So vaccination still is the message, in spite of the very high levels we've already achieved.
That the increase in people going for testing is connected to schools reopening. What age profile are we seeing being tested and testing positive?
I'll ask Professor Nolan maybe to cover that, but it's the 5 to 12. Principally, we've seen a very significant change.
Yeah, principally, the testing of children under 4 has tripled, with almost no increase in cases detected. The testing in children aged 5 to 12 has tripled, with, as I said, about a 50% increase in cases detected. As I say, that may be simply increased ascertainment. In other words, that it's not an increase in incidence, you're just finding more cases because of the very high level of testing, and we'll see that in the next couple of weeks. Testing is declining, or the demand for testing is declining in almost all other age groups as vaccination, because in those age groups it's been driven by people developing symptoms and coming forward looking for testing. Whereas in the younger age group, it's been driven by the large number of the concern about contacts and those asymptomatic contacts coming forward for testing. And this phenomenon is usually transient. So not only is there consideration about how policy might change in coming weeks, but also human behaviour will change in coming weeks as people become less concerned about the impact of school opening. That's what we saw before.
Third is NPHET still encouraging people experiencing symptoms to go for testing? When would you expect a shift in testing as recommended by medical professionals only to that test theme?
And in a sense, it's the same answer, Chair, that like when we think the criteria are satisfied, and as I say, we're not far away from that point, we won't continue to emphasise the importance of all individuals with symptoms being tested. And it'll be more individuals where, on clinical grounds, a doctor believes it's important to understand what the nature of their symptoms is caused by. And so we expect that to be far smaller volume of testing for clinical purposes, and the test essentially being ordered by a doctor as opposed to being ordered by an individual. But we're not at the point yet where we think that change can be made, but we think we're close to it.
Why we're seeking such high case numbers amongst vaccinated individuals. It is important to maintain confidence, especially if a third jab is required, and what specific new challenges has Delta variant presented. Who wants to run with that? Don't be shy.
I think there's a very simple answer to that, which is that if the entire population was vaccinated, we would still see some cases, and then all of those cases would be in vaccinated people. Yeah. So at very high levels of vaccination, it's not surprising to find that about half of your cases are in vaccinated people. And what that's really telling you is that you're only seeing the tip of an infection iceberg there, that for every infection you see in a vaccinated person, the vaccines are preventing 7, 8, 9 infections in other people. So the unfortunate thing about that statistic is what you're not seeing is the infections that have been prevented in the vaccinated people. You're just seeing the modest number of breakthrough infections in the vaccinated people and a similar number of infections in unvaccinated people. And then the further point is when you go on to look at the numbers then admitted to intensive care or the numbers sadly dying, they remain quite radically different. In the significance of an infection in a highly vaccinated population is different because that infection is significantly less likely to progress to severe disease and very much less likely to result in a death, particularly in the healthier and younger part of the vaccinated population. So in no way should that statistic erode confidence in the vaccination program. We should constantly be reminding ourselves of the huge numbers of infections that vaccination is preventing and the huge numbers of hospitalizations and deaths that vaccination is preventing in those people.
Two more questions from the Chairman. We saw difficulties in procuring enough flu vaccines last year. What steps have been taken to avoid that again this year to meet the demand, of course? And the last one is, in NEFIT's view, how do the daily case numbers stack up against the modelling?
On the second question, bring Professor Nolan back in. On the first, the HSE is in the process at the moment of putting arrangements in place to commence the flu campaign, and the HSE will be in a position, I think, to provide a direct answer on that question around procurement.
Very, very quickly, as mentioned in previous evidence, from our June models, optimistic to central scenarios projected between 80 and 100,000, 120,000 cases. And we've had 100,000 cases, so we're just slightly worse than optimistic against the June models. And then the late August models, essentially we're tracking slightly better than the optimistic scenario.
Questions from Senator Sean Kine. We have two questions. What variants of COVID is the CMO keeping an eye on or monitoring on a worldwide basis with regard to its impact on the population? And two, for Professor Butler, what programme of vaccination against the winter flu is planned and is it likely to be an issue worldwide this year? Two questions. Who wishes to run with the first?
On the first of those questions, every aspect, I would say, every aspect that we think is relevant, we keep monitoring and will continue to do so over the course of the winter. And if it's possible, Chair, there are one or two slides that if we were to show them to how we compare both to the neighbouring regions of the UK, but also to the rest of Europe in terms of our current incidence, it might be able to illustrate where we stand in relative terms. Or if you prefer, we have the slide deck, which I know time doesn't allow us to go through fully, we can make available to the members of the committee. But I think some of those, there is a kind of a picture tells, whatever that phrase is, much easier to show and demonstrate how we're doing and what we're keeping a track on as compared to other countries by showing you some of those graphs, if you have time for that.
To further copies of some of those graphs or transmit them to the members for that purpose?
Yeah, or we can put them up on the slide on the. We can share them with you now if you wish.
Question while the slides were being put up, if that helped. The question was regarding the influenza seasonal campaign, and that has been scheduled to roll out with the recommendations that for the usual groups be vaccinated. The modifications this year are that the COVID COVID-19 vaccine can be given at the same visit or separated by any interval from the seasonal flu vaccine. And the only other modification to the programme is that an adjuvanted influenza vaccine is being recommended for those 65 years and older because it's shown to have increased protective effect in those age groups. So seasonal flu vaccine planned to start, and the good thing is that hopefully by not combining them together, but that they can be administered on the same day, that might optimize the rollout of the vaccines together, for example, in the nursing home facilities with the booster shots.
Well, just a couple of questions myself. First of all, how is, from your observations, how is the population's natural immunity building up and resisting the virus? Is it in accord with expectations, or is it short of that? And who'd like to run with that?
Well, again, I might ask Professor Butler. I'll defer to her expertise as an infectious disease expert on that question.
Well, I think the answer to that is how we've seen the decline in numbers in hospitalizations and in severe illness and death, which is sort of the far end of the wedge, but showing that the vaccine program is working and that people are developing protection against severe illness and death, which was the target of the vaccination program. Now, I just noticed, for your interest, in Public Health England data that's just released, I think within the last week, where they have done antibody testing throughout the population for how it reflects, and showing that there, about 90% of the population at this stage have some level of antibodies, either from natural infection or from vaccination at this stage. So with our very high vaccination rates, we can assume that at least in our adult population, we certainly are reaching levels of immunity and protection against severe illness and death, as was hoped for.
There's another question. My second question is in relation to frontline workers. We know that, unfortunately, many frontline workers pay the ultimate price for being in the front line, and we extend to them and their families our sympathies. We also have a number of frontline workers who have reacted to the vaccines, and we know again that all vaccines have a potential for reaction, some greater or lesser than others. How do we deal with situations, and how are you dealing with the situation whereby a frontline worker has had one dose of the vaccine, is warned not to have another by medical practitioners and experts? What do they do? Do they continue on? Do they exit from the front line? What is the advice? And can we be sure that they're not in any way penalised for being in that category that reacts to the vaccine?
Again, Professor Butler might wish, but just if you can see it.
Yeah. Yes. First of all, it is one of the good things in this program that we have more than one type of vaccine. Unfortunately, the reactions seem to be pretty much type specific. So, for example, and people will be familiar with, for example, the AstraZeneca, let's start with the RNA vaccines and the allergic reactions to it. If they have had reactions to that, they can have a different type of vaccine. And similarly with the AstraZeneca, if you have had an adverse outcome related to that, then it is possible to get an RNA vaccine and to complete it. And for those groups, there have been a much larger group who, for example, have thought they have had an allergic reaction. And while we have not been directly involved in this, I'm certainly familiar with it. The HSE have done an amazing job. In fact, they set up special clinics for those who thought that they had allergic reactions with supervision if it was deemed that they still were appropriate to get that reaction and to enable them to become vaccinated. A lot of work had been done by the allergy group together with NIAC and others to get good information for those who think they might be allergic to vaccines and to overcome it. So I think a number of steps have been done. there are always some people who will not respond to vaccine, and for those, the whole onus is on us to continue to drive the force of infection down in community and to continue our public health measures to protect them.
We're coming into the last 10 minutes or so, and we have still a couple of speakers, and we'll be short of time, but we will try to cover. Deputy Cathal Crowe. I saw you lurking out there somewhere. Where are you?
Thanks, Chairman. Chairman, just confirm I'm here in LH 2000. You can see me on screen, can you? Yeah, I can hear you.
You were?
Hello, Chairman.
Yes, we can see you here, Deputy Crowe.
Sorry, Chairman. So just want to thank NPHET for being before our committee this morning, and thank you for all the work that both NPHET and NIAC have done and continue to do over the past 18 months. I think we're in a pretty good place relative to where we would have been at the start of this year and in springtime. So I have a number of questions I'd like to put. If I could first of all to Dr. Butler just ask, vaccines that are outside the big three that the EMA have approved, I'm referring to the likes of Sinopharm, which a lot of people who've lived in Asia and the Middle East have been vaccinated with. Is there any word coming from the European Medicines Agency and indeed from NIAC here in Ireland in terms of accepting that the bona fides of Sinopharm and determining that those who have been vaccinated in Dubai, Qatar and other places who've now come back to Ireland, that vaccine is deemed to be safe and with the same bona fides as Pfizer, Janssen, etc., and that it would qualify in terms of digital COVID certification?
We will be guided by both the HPRA and the EMA review in terms of the vaccines that are considered appropriate within the area. At the moment, the vaccines that are recognised in terms of ensuring that someone is fully vaccinated are those that are licensed by the EMA, the FDA and the MHRA. So that is where we will get our guidance. The other vaccines, there are other vaccines under rolling review in the EMA, including, for example, the Sputnik vaccine, and we will be guided and take advice from there.
Okay, thank you, Dr. Butler. If I could next ask Dr. Ronan Glynn, I just have two questions I wish to put to Dr. Glynn this morning. The first one relates to school buses. There has been NPHET advice and government policy now is that school buses can carry 50% capacity, but yet all forms of public transport are now gone back up to 100%. So I travelled this morning to the Dáil on Irish Rail, and it was, a lot of people travelling in the train. It's good to see, but it's hugely frustrating and largely inoperable in rural areas to have only half capacity in school buses. I was just wondering, where did that thinking come about from, and when do you expect to review it?
So we wouldn't have given specific advice in relation to the return to full capacity in public transport. That was a government decision. Obviously, all of these things remain under ongoing review, and clearly, again, as part of our ongoing look at data specifically around the return to education over these number of weeks, we're considering all of these issues. And again, as per the CMO's comments earlier, we would hope to see a transition across a range of measures, albeit ensuring that the basic preventive measures remain in place through the autumn and winter.
So I think this can work quite well in Dublin, where a teenager can hop on their local Lewis or Dublin bus and make their way to school and home again in the afternoon. But it's quite different in a rural county like Clare, where the local school bus might be bringing children, across a 10 or 12 kilometre journey each day. And a lot of them are in the same bubble when they go to the school environment. So it is proving very inoperable. And I hope that it will remain under an urgent review, because we've had two kind of chaotic weeks now so far in the school year. My final question to Dr. Glynn relates to international travel. So we've had a pretty good 6 or 7 weeks of international travel, I would say. And I'm saying that as someone who's watching this through the aviation lens and in the international travel lens. But I was just wondering, from a public health point of view, has it been as successful as I consider to be? Can more be done? And I also want to know, have you spoken with any counterparts? I know you often speak with your colleagues across Europe, but have you spoken with people in North America? It concerns me that there are still very significant restrictions in terms of Irish people travelling to the United States. I was just wondering, have you any dialogue open with counterparts in the United States in that regard? Thank you.
If you don't mind me coming in here, Deputy Crowe, we haven't had a specific discussion, and I take it you're implying the idea that we'd advocate that Irish people would be exempted from the restrictions that the US has in place in terms of its own travel arrangements. Is that what you're? No, we haven't done it. I think what we continue to do is to cooperate in line with all the European agreements in relation to travel. In broad terms, travel has gone well in this country. We've had, and when I say that, I'm talking about the provisions that were put in place specifically to try and mitigate and manage down as much as we reasonably could the level of importation of the virus. We had mandatory hotel quarantine arrangements in place, and as you're aware, we provide ongoing advice to the Minister based on an ongoing assessment that now relies on the European Centre for Disease Control assessment around threats coming from other European countries, as well as what we call Annex 1 countries, countries that we regard as having low enough incidence for us to consider them as being equivalent. You could look at it in those terms. To make those assessments as to which of those countries should be the subject of mandatory hotel quarantine or any other provisions in relation to international travel. We think our reliance on that as a measure will decrease over time, which should be good news, and because in broad terms, much of the world now is experiencing the same, whatever its level of incidence, that incidence has been driven by the same variant that we're currently dealing with. And that has had an effect in terms of the nature of, and I guess, the relative import of different regimes in different countries at a different point in time. We're always going to have to be mindful as we travel individually of what we can then do to both assess the risks that we subject ourselves to or are going to be exposed to, how we can best then try to prevent those. I think the airlines have done a great job in terms of trying to ensure that the process of travel, in other words, transmission while you're travelling, is minimised as much as possible. And then beyond that, then it will be for the individual to make the assessments in terms of either social or business or other engagements that they have in the same ways that they should do as if they were at home. And in broad terms, Europe is experiencing a significant challenge in terms of the level of infection that it's experiencing. We've experienced it in Western Europe, maybe ahead of other parts of the rest of Europe. But we think that heretofore those arrangements we had in place to try and minimise the importation of the disease had an important role to play, and will continue to heighten, maintain high levels of understanding of people on the part of the public around the risks that arise to you as you travel internationally in relation to this disease.
Thank you, Dr. Olin. Can I apologise because this is how Microsoft Teams is, but when I was diverting all the questions to Dr. Glynn, I couldn't see you on screen. I thought you'd stepped out, so apologies. And I can now see the three of you on my screen, and just again to thank you for what's going on. And
thank you, Deputy. Thank you, Deputy. We have two last questioners. We're out of time, by the way. Sorry about that now. Time is inexorable. It comes to an end all the time. We have Senator Martin Conway, and then we have Deputy John Lard.
Yeah, just very briefly.
And we have 5 minutes altogether.
Just very briefly, and thank you for facilitating me coming back in. I'm just a little concerned about the high levels of disease in Northern Ireland. And I'm just wondering, Dr. Houlihan, have you been monitoring the situation in Northern Ireland from the perspective of the border counties? And have you concerns particularly about our border counties? And, do you envisage that there's a greater threat of maybe a regional lockdown in the border counties because of the high levels of infection in Northern Ireland?
Say no to the last question there in relation to regional lockdowns just on its own merits. That's not in our planning at this point in time. In a more general sense, yeah, we share the concerns that the Northern Ireland authorities themselves have about the very high levels of infection. As things stand, and we have, and you'll see in some of the graphs that we'll circulate, we have incidents in the last 7 days in Northern Ireland at 535 per 100,000 as compared to 190 here. So it's heading for threefold the levels of infection that we've had here, and they've been persistently higher than us going right back to the middle of June. So the experience that we've had in Ireland of this so-called fourth wave is a much lower level of incidence right the way through than every other part of both Great Britain, the three countries that make up Great Britain, and Northern Ireland, but particularly Northern Ireland. And they continue to experience the high impact of that in terms of hospitalisation. We have a regular arrangement where my colleague Michael McBride and his team and I sit down now every fortnight to review the disease and to look in particular at some of these border issues. There's no doubt that at least in part what is driving a persistent high incidence that we've seen in the counties of Monaghan, Donegal in particular, Cavan, and from time to time some of the other border counties like Louth, reflects the incidence that they've experienced, particularly over the last 2-3 months, is much closer to the instance that Northern Ireland is experiencing than the experience that the rest of the Republic of Ireland has experienced. So that's been a particular challenge for people who live in those border counties. That's not to say that all that can be explained by the infection, if I can put it in these terms, spilling over the border. There's a lot of mobility between certain parts of some of those counties and Northern Ireland. It may also be the case that similar, social circumstances that lead to spread and transmission in Northern Ireland apply in some of those counties as well. So it'll be a mix of those kinds of regions, but there's no question but that the border counties of Donegal, Monaghan and Cavan have experienced a very significant challenge with high levels of infection that reflects much more what's been happening in Northern Ireland and what's been happening in the rest of the Republic of Ireland, where our disease experience has been much better than any part of the UK.
Thank you, Doctor.
Thank you very much. Deputy John Lahart, last question.
Not a question.
It's a comment.
Three witnesses will be delighted to hear. You can relax after your long session, and we're very grateful again. Chair, the first COVID case in Ireland arrived on the 29th of February last year. It seems like eons ago. A very significant turning point. I feel a little emotional thinking about it. I can't imagine how you and your team felt. So it seems now, without being complacent or taking anything remotely for granted, in a guarded way, that we are in a phase of emergence and are coming out of the emergency. So on behalf of myself, and I don't want to be so bold to speak for the committee, but I know I do speak for the committee and so many Irish people, we discovered in that time that through NEFIT, NIAC, the HSE and the other statutory agencies, volunteers, the Armed Forces, Defence Forces, Gardaí, nurses, teachers, retail staff, emergency staff, all of those associated with every phase of this and who continue to be associated with every phase of this, that Ireland had a resilient, independent, most importantly, scientifically grounded team that stood its ground when it needed to stand its ground and yielded when the evidence suggested that yielding was appropriate. I want to thank you personally and all of those who work for you on behalf of the constituents that I represent, particularly those of you who endured seen and no doubt unseen sacrifices during that time. The amount of hours that you invested in this whole endeavour on behalf of the state and that you continue to do and will continue to do. I want to thank you for your fortitude, your resilience, your consistency and your dedication to the task. And so Irish people will know that if, and God forbid it would, that if we entered an emergency phase again, that we have exactly the right personnel to guide us through that again, and that there's no need to fear, and that we know so much. And in summary, Chair, I just want to say, which I know so many people feel, the country owes you an incalculable debt, for which we're grateful. We've never met you personally, and I look forward to that opportunity, perhaps, Chair, in a social context, which is allowed now, to express our thanks on a one-to-one basis. It's always been on a screen. So thank you, as I said, on behalf of the people that I represent. Your debt, our debt to you is incalculable. Keep up your good work. I hope you do get a chance to recharge your batteries from time to time. I imagine you're all exhausted and your teams are exhausted, but you carry the very, very best wishes of all Irish people. Thank you, and thanks for the opportunity, Chair.
And may I add to that as well, as Chair today, and I'm sure on behalf of the Chairman, that I fully and strongly endorse the remarks of Deputy Lahart. I think that the role you had to play was very often a lonely path that you stuck to despite criticisms and despite adverse expert opinion. And we put the expert in commas there, quotation, because there were many of them. And as Deputy Hart said, you continue to stick to your ground in the public interest and the interest of the health of the nation. I think you did extremely well. And that was a lonely road at times. I was part of the committee, the COVID committee earlier. We met with many of you during that period, and we listened to the comments. I think that we have to also recognise the people who were supportive, the people who helped you out, the people who stood by you in difficult times. We have to remember also the people who lost their lives, who were the frontline people that I referred to earlier on, and who continue to risk their lives and their well-being in the course of their work. There were many, many of them. And of course, we've gone over the number of casualties in the country of more than 5,000 already, which there are those who were cynical in the beginning and said, you know, this is only a flu, it will pass over. Well, that wasn't true, of course. So to each and all of you, both here and outside, we have to say thank you for your sacrifices and your dedication, and also to hope that, as Deputy Hart said, that you do have an opportunity to take time out and recover yourselves from it. To each and all of you this morning, we say a particular thank you. That concludes the business for this morning, and the meeting now stands adjourned until Wednesday, the 22nd of September at 9.